that process is called diapedesis. When those red blood cells get out into the area around the veins in the nervous system, they degrade just like they do in any other part of the body. And what happens when red blood cells degrade is their protein denatures. They have a lot of protein. The protein that they have is called hemoglobin. That hemoglobin gives up its iron. And the iron is left in an area where it's going to cause a toxic reaction in the area around the veins. And that toxic reaction leads to an abnormal immunologic response, which then causes multiple sclerosis plaques to form. So this is the big idea. This is the way CCSVI leads to MS plaques, typical MS plaques. And what's very important about this, I think, for us to realize is that all the statements about CCSVI being MS or not being MS, none of those really matter. What really matters is that you look at this and understand that the antecedent event, the abnormal venous flow, eventually allows us to explain the process that is already being treated, maybe appropriately, maybe not, by anti-immunological drugs, by drugs that are there to decrease reaction. Now, perhaps what we're talking about is the fact that we need a two-pronged approach. Maybe we'll end up understanding that we need more than a two-pronged approach. But what I think is very important is for us to understand is that this does not discount what the neurologists have said for 40 years. So any neurologist who's upset about this theory, unfortunately, isn't really understanding that we're saying, that's great. You guys have done a lot of great science to prove that there's an immunological abnormality that needs to continue to get treated the way you treat it. We're not discounting that. That's still occurring. But what we're saying is that there's more. And there may be something we can do about the more by treating the CCSVI component of this disease. Obviously, this is all theory at this point, and everyone recognizes that it's theory, including a multidisciplinary group that met recently, last year actually, to discuss, this was a consensus panel that met to discuss what research needs to be done, what should be on the research agenda to figure out the right way to address CCSVI and its relationship to multiple sclerosis. And so this was neurologists, vascular surgeons, interventional radiologists, interventional cardiologists, pathologists. Everyone came up with the concept that in order to move this forward the way it should be moved forward, we need to do what are called RCTs, or randomized controlled trials. And those are really what you've heard about as far as level 1 science, good science to prove that CCSVI is related to MS and should be treated. The problem with that kind of science is that it takes a huge amount of time, a huge amount of money, a huge amount of effort and patience to get it done. And more importantly, what this group recognized was that even though that's the direction we need to get to eventually, randomized controlled trials, the fact is, between now and then, what we need to do is encourage individual site investigators, like the people at Dr. Arata's group, like the people at Gary Siskin's group, like the people at our group, to continue to do what they're doing to move this to the point where we can do randomized controlled trials. And it's interesting, the president of the Society of Interventional Radiology is actually one of my partners. And in his most recent newsletter to the society membership, which is about 5,000 interventionalists, he said if we are deluding ourselves into believing that we shouldn't do any of these procedures, and he used CCSVI specifically as an example, until we have level 1 randomized controlled trial data, then we're never going to be able to start treating these patients. Coronary artery disease is a great example. We all know that coronary artery disease is accepted as a process that requires endovascular management, stent placement, coronary angioplasty. Very, very common. It was 35 years after the first coronary angioplasties were done before a randomized controlled trial was done. So I think that what we need to do is accept the fact that it takes a very long time to get to the point where you're going to do these things the way you need to, and there are steps along the way to get us there. That's where we are now. I do have some of the data, though. Granted, we don't have level 1 data, but we do have, I think, reasonable science to start us off on the right foot, and I'm going to tell you about some of these trials. Most of this is safety data. Not all of it is outcomes data, but it tells us how safe the procedure is. Obviously, Dr. Zamboni was the first. He talked about CCSVI and the treatment of CCSVI and MS back in 2009. This was published in the Journal of Vascular Surgery. 65 patients were treated. 35 of them had relapsing remitting multiple sclerosis. The rate of being relapse-free was significantly better in patients who had angioplasty versus patients who didn't. Only 27% relapsed at 1 year who had been treated versus 50% who hadn't been treated. On 2 different validated scales of improvement, patients were found, at least relapsing remitting patients, were found to continue to have persistent improvement at 18 months. And probably what's very important about this is that he found that the restenosis rate, or the likelihood of these veins narrowing back down again at 8 to 9 months, was very high, 50%. The good news about this is that if he had got out some data that said, when I do an angioplasty on a jugular vein, the restenosis rate is 10% or 20%, or most of us in interventional radiology would have very appropriately said, we don't buy it, we don't agree. Because we've treated veins with narrowings in the rest of the body for a very, very long time. Even young guys like me have treated it since 1997. And the fact of the matter is, veins narrow when you angioplasty them. And this is about the rate that they re-narrow at. So veins are acting the way they should act. And I think it's a very important point that came out of this research. Dr. Kostecki had a little bit less favorable, but still favorable results. He looked at 36 patients. He followed them out to 6 months. He found that in patients who had angioplasty alone, the restenosis rate was about 33% at 6 months. Remember, Dr. Zamboni's was 50%, 47% at 9 months. And he found that the restenosis rate with stents was higher, 55%. Again, this is how veins act. If a stent is placed into a vein, the vein does not like to have veins only like to have blood going through them. So whatever we do to them, they don't like it. And especially when you put a stent, they do restenosis. And our job is to try to find a way to keep them open as long as possible. He found that there wasn't much change in the EDSS, which is the most common scale most people use clinically to look at patients' clinical symptoms with MS. But he did find that there was an improvement in the MSIS scale at 3 months, and he also found a significant improvement in patients' fatigue and health index scales at 6 months. He reported no complications. Dr. Haskell, who's a former president of the SIR, looked at 18 patients. They did 19 angioplasties in these patients. He ended up placing stents in a big number of the patients who he treated, almost 50%. That 50% number, I think, probably has to do at least somewhat with the size of the balloons that were used. You can see here that his balloon size, and this was pretty early in the experience with CCSVI, so it's possible that people were being a little bit less aggressive than they have become. But his balloon size was between 10 and 16 millimeters. I would say that now balloon sizes, very, very few people are using balloons under 14 millimeters in the jugular vein. It's between 12 and 14 to start. So it's possible that he ended up using more stents because the balloons they were using were smaller, okay? He did find, however, that the quality of life, the MS quality of life scale was used, a validated scale, improved significantly and was uniformly positive at 3 months in the patients that they treated. He reported on an allergic reaction to Plavix, which we've seen in our patients, it's very common. And he also reported on an internal jugular vein rupture. What's important about that is that the venous system, unlike the arterial system, is very forgiving in the sense that if you do have a vein damaged or a vein ruptured, almost always we can control it with the balloon that we have in place, and they were able to control this rupture in their case. Mondato, who was Dr. Siskin's partner, this is a guy from Albany. He presented at last year's annual SIR meeting. They had looked at a bigger number of patients. They did 247 procedures in 231 patients, and 87% of those were angioplasty alone. Only about 11% had stents. That's getting closer to the numbers that most people are talking about now as far as their percentage of stent use. He reported some complications. This was not done as an outcome study. This was done as a complication study, and they had a very low rate of complications. Transient headaches in 8.5%. We do see that. Neck pain in 15%. I would say we get neck pain in a higher number than that. Most patients who have had the procedure have some pain at the time when we do the balloon dilatation, at least pressure. And I'm seeing people in the audience who we've treated nodding yes. Thankfully, it's transient, and you can ask them about the discomfort to let us know whether we're doing okay with pain management. He did describe one incidence of stress-induced cardiomyopathy. What that means is that the rhythm of this person's heart changed. And I'll talk a little bit about more of that later, but what you should understand is that we start working down low, usually at the groin level, at the level of the upper thigh, and in order to get to the level where the jugular veins are, we need to go through the heart, which means that our catheters are passing across the area where your heart's rhythm is generated, and so we have to watch very closely during these procedures to make sure that people's rhythms don't change. It does occur fairly frequently, so I guess that's my plea, to make sure that patients are having procedures done in a monitored setting. Very safe, but safe when done correctly. And finally, Ludiga talked about 331 patients. They used stents only if angioplasty failed. They did use a pretty significant number of stents, and so I wonder why their stent rate was so high. But even with that, out of the 331 patients they treated, their complication rate was remarkably low, 1.4% and 2.1%. So very, very safe procedure. And the last study that I'll show you here was a study that Dr. Ponik described last July at the CCSVI symposium, and he did have some outcomes. 265 patients, the majority were relapsing remitting. Again, they used the MSIS scale. Patients were improved at 1 month. 77% of patients improved at 1 month, clinical improvement, and that improvement was durable. It persisted at 6 months in 67%. So I think that's great numbers with very, very low complication rates, less than 1% for minor complications and 0% for major complications. that means a clot in the vein where they made their access. The last trial, and this isn't really an outcomes trial, it's not a treatment trial, that I want you to be aware of, is very recent data. I just got this off the internet. Some of you here probably are aware of it. This was a meta-analysis. A meta-analysis is when a researcher takes all the published data, anything that's been published in a peer-reviewed journal, and they crunch all of that data down to the articles that are actually scientifically valid. And then they take those scientifically valid articles and they review them to get an idea of what this is all about. They looked at actually 470 or so papers that talked about the presence of ultrasound-defined CCSVI in patients with MS versus patients without MS. And when they whittled down to the papers that were done appropriately, that had good controls, so they looked at patients who didn't have any neurologic disease versus patients with MS, that were blinded. In other words, the people who were doing the ultrasound didn't know whether they were evaluating patients with MS versus not with MS. So very good science. When they whittled this all down, their final conclusions were that there is a strong and statistically significant association between CCSVI and MS. They also suggested further research needs to be done, but this is looking at a big number of patients to talk about the fact that there is this strong association, which I think we can all feel good about. And this is very recent. This was actually sponsored by the Canadian Institute of Health and published by the Canadian Medical Association Journal. So you can get that online if you want to read the article. It's a very good article, and I think it's easily readable. There is a lot of work going on. So these are all the studies that are being supported by grants right now. At the time when I put this together, there are about $2.4 million worth of grants out there, a lot of them in Canada, but also a lot of them in the United States as well. Most of these are looking at ways to assess or define the presence of CCSVI as opposed to treat. So they're looking at, MR evaluation of patients with MS versus without MS, MRV rather, ultrasound versus MRV. But there are a couple of trials that are ongoing treatment trials, and I'm sure you know about some of these. The two that are really, I think, going to give us a lot of good information are the PREMISE trial, which has completed its recruitment now at Dr. Siddiqui's group in Buffalo. That's the PREMISE trial. And what this means, the 20 patients, venoplasty versus sham, this is why these studies are so hard to do. This is a randomized controlled trial. And what happens in this trial is patients don't know whether they're getting treated or not. And the people who are looking at the angiograms after the procedure, so the doctor doing it obviously knows what he's doing, hopefully. But after the procedure, when a reviewer will look at these images and determine whether the flow was improved in these veins, that person doesn't know whether the before and after images came from a patient who had had an angioplasty versus not. So the sham is patients who have everything done but the balloon inflated. And you can see why I'm a little concerned about the possibility of a sham with people who have symptoms, because most people in the community know that when you blow the balloon up, patients are aware of it. So somehow you need to get it to the point where patients are either sedated enough or have the sensation that they're having the balloon inflated in order to make this a valid sham.